Hi, good morning, everyone. Welcome to this week's Department of Medicine Grand Rounds. Just a few housekeeping tips before we begin. Please just keep yourselves on mute during the presentation. Additionally, we also ask that you hold your questions and comments till the end, at which point you can unmute yourselves or use the chat box to communicate your comments and questions. Lastly, the CME information is here on the slides at this time and will be placed in the chat box later in the presentation. Today, our speaker is Dr. Ahacc Sharma, joining us from the Division of Cardiology for a presentation on TAVR. Dr. Sharma joined the Division of Cardiology at Rutgers as Director of the Cardiac Cath Lab and Interventional Cardiology Program. He completed his fellowships in Interventional Cardiology at Massachusetts General Hospital, Harvard Medical School, and in Structural Congenital Heart Disease at Rush University Medical Center. Dr. Sharma is actively involved in cardiovascular outcomes research, especially in the fields of coronary artery disease and transcatheter valve therapies. He has co-authored and authored more than 100 peer-reviewed manuscripts and book chapters. He also serves on the editorial board and as reviewer for several reputed national and international medical journals, and is involved at the national level in committees for several associations, including the Society of Cardiovascular Angiography and Interventions. His clinical focus includes, but is not limited to, transcatheter mitral valve therapies, transcatheter aortic valve replacement, left atrial appendage closures, and high-risk coronary interventions and mechanical circulatory support. We welcome you and we thank you, Dr. Sharma, for joining us to give this talk on TAVR.
Jana, thank you so much for your kind introduction, and good morning, everyone. Thank you for joining me today in this Can you guys hear me?
Yep.
Okay, good. So good morning, everyone, and thank you for joining us today for this discussion about TAVR and how this procedure start from very beginning and used as a niche therapy to its current state where it's almost standard of care. For this particular talk, I have no relevant disclosure. And before I begin, I would like to share with you guys a brief animation about this procedure so that we all can understand how we able to achieve such a marvelous achievement in cardiovascular medicine with utmost patient safety and great clinical outcomes. So this procedure, the fundamental is you cross the native aortic valve with a wire and then put a bioprosthetic aortic valve which is crimped over a balloon and advance that aortic valve over this wire all the way across the native aortic valve. There are several technical nuances about the fine adjustment, how we do it to achieve the perfect location without compromising the coronary ostia and without damaging the annulus. But once we are satisfied with the position, then we inflate the balloon. What it does is open up the native aortic valve and also expand the bioprosthesis. I will show you on this animation how we do that. In this position, we're trying to adjust so that we can put our bioprosthesis at exactly the right spot. And then under rapid pacing, we inflate the balloon to expand the bioprosthesis. And once we are satisfied with the position, we remove the catheter and the wire and suture the access site using usually 2 percloses. So you can see that we never remove or take out the native aortic valve because that actually acts as an anchor to support the bioprosthesis. And this allow almost a functional new aortic valve. That's why they use TAVR, which is a transcatheter aortic valve replacement, in contrast to the prior use of the word TAVI, which was transcatheter aortic valve implantation. And now with this in mind, let's start our journey, which almost started more than 500 years ago when Leonardo da Vinci first provided us with the accurate description of native aortic valve. This is the picture that he draw. It's from the UK Royal Collection Trust. And you can see he described a tri-leaflet structure sitting between the main artery aorta and the main chamber left ventricle. Since then, our understanding of aortic valve has increased leaps and bounds, but there are many giants who contributed to our this understanding. First description of aortic stenosis can be traced back to Dr. Lazare Rivera, who described in his book Opera Medica Universa autopsy finding of one of his patients. He described some growth and vegetation on the aortic valve leading to narrowing of the orifice, which most likely secondary to infective endocarditis, as we know, but that was somewhat closer to stenosis, which was provided. More accurate description was given by physician to Napoleon, Jean-Nicolas Corvisat, in his book, where he described aortic stenosis on autopsy as ossified and united aortic leaflet so close that even little finger cannot put across that aortic valve. And that, as we know now, resembles close to senile degenerative aortic stenosis. Since then, we know our understanding of aortic stenosis and its related pathologies have significantly improved. That this is the native aortic valve, which is a tri-leaflet thin membranous structure. In most of the patients, we have 3 leaflets, but in some congenital abnormalities, which is up to 1 to 2% of the population, people can born with a bicuspid aortic leaflet or aortic valve, like this picture, which shows pseudo-raphe at 6 o'clock, and this is functional bicuspid aortic valve. What this does is predispose to premature or acceleration of aortic stenosis early in the life. In third world countries where rheumatic heart disease is still very rampant, you can see rheumatic heart disease leading to aortic stenosis and the classical fish mouth appearance as shown here. However, the most common one is degenerative senile aortic stenosis, where there is a calcification and thickening of the aortic leaflets, leading to narrowing of the outlet. And this is the most common etiology for aortic stenosis in the Western Hemisphere. In last century, the average life expectancy in America has increased by more than 30 years, and it will continue to improve because of improvement in the healthcare science. And it is expected that in next 30 years, the number of 85-year-old and above patients will be triple. So you will see a lot more of senile degenerative aortic stenosis as we move along. And based on our understanding in last 60 years, we know that the outcome of severe AS is pretty bad, especially if it is left untreated. And the first real understanding of the prognosis is from Dr. Ross and Braunwald study 1968, where they retrospectively study the autopsy finding and correlate with the symptoms, and reported that if patient have angina, then the mortality is within 5 years. You can have expected mortality without treatment, and that time there was none. The prognosis is even more worse if patient have presentation as a heart failure, where the mean survival is almost 2 years. With the current understanding and the studies, we know that this exact description of 2-year, 5-year with the symptom onset is not really accurate, but the bottom line is if patient has symptom with severe aortic stenosis, outcomes are poor, and that need to be intervened on. So what is the intervention which is improving the outcomes in terms of symptoms and also survival? Historically, the surgical aortic valve replacement is a conventional therapy. Patient is a mechanical obstruction and it needs to be replaced with a new aortic or mechanical aortic valve. However, almost 30 to 40% of surgical evaluation find patients are not suitable because they have a lot of comorbidities. They are elderly, frail patients and cannot withstand this high risk procedure. So almost 1/3 of the patients were not offered the surgery because of the underlying risk from the surgery itself. So what is the role of drug therapy in those patients or in general among the patients who are not a candidate for surgical aortic valve replacement? And when we review the literature, including the randomized trial, and there were few, study the role of bisphosphonate, your ACE inhibitor, beta blocker, none of the medication have shown to decrease the progression or cause regression of aortic stenosis. So drug therapy has no role per se to treat aortic stenosis. It can be used for management of other comorbidities like hypertension, heart failure, but not for aortic stenosis per se. So what is the role of catheter-based therapies? This was first investigated by Dr. Davis in 1960s, where he proposed a protocol with a cone-shaped valve, which can be, implanted through the carotid arteries. Especially in the animal models, it was tested with aortic regurgitation. Several other prototypes were also proposed, and the core underlying fundamental was these prototypes inflate during diastole to prevent the regurgitant flow going back to the left ventricle, and inflate and then deflate during systole to allow the forward flow of the blood. And these efforts continue almost till mid-1970s. Here you can see one of the advanced version of those prototypes by Dr. Philip. It's a single cusp valve, but they all have inherent limitations. Number one, they all need to be connected to an external system for regulated deflation and inflation. And second, none of them are permanently implanted valve. They all have a kind of a temporary way in patient with aortic regurgitation. And none of them address the core problem in the stenotic situation. The first real effort which addressed the aortic stenosis with catheter-based approach was by Dr. Crevier in 1985, when he performed first balloon aortic valvuloplasty in a 77-year-old lady who had severe aortic stenosis and was not offered surgical aortic valve replacement because of underlying comorbidities. He has successful results. The gradient decreased by more than 50%. But subsequent reports and the cases were not that successful, and there was serious concern about the safety and efficacy of this procedure. And the primary reason was these require large bore access, and the outcomes, even if you achieve success, they are not sustained because of high restenosis rate. So what can be done is you need to implant a prosthesis which will remain that stenotic lesion open and allow the forward flow. First successful attempt in this direction in animal model was performed by Dr. Anderson, who implanted an expandable aortic valve in a pig model. This was successful in animal model, but cannot reproduce in humans because the valve required a large bore access, and the delivery system was 41 French, which is not feasible in most of the human arteries unless you go have direct aortic access. So the efforts continued to achieve the holy grail of successful implantation of aortic valve prosthesis. And the next significant attempt was by Dr. Bonhoeffer and his team, who used a bovine interjugular vein and sutured that vein inside a platinum and iridium stent. Now, this was used in animal model and subsequently also in human with pulmonic stenosis. But because of the fragility of that internal jugular vein and the stent itself, it was not deemed to be appropriate in high pressure conditions like aortic valve, where the valve is exposed to all arterial pressure. So that might not make the bioprosthesis functional in long term. So continued effort, and again, the giant Dr. Alain Cribier from France, he developed his own percutaneous heart valve, which was used in the sheep model, and the delivery system was 24 French. This is in contrast to the prior one, which was 41 French. So significantly modified and low profile valve. He tested this valve initially in animal model and then also in pulse duplicator models. What it does is it proves the durability of the valve that can be used on multiple cardiac cycle and many more years. Based on his successful result, the valve was deemed, that this can be used in humans. And now we waited for the big moment, which was April 16, 2002, when we have 54-year-old gentleman, which was have severe aortic stenosis, not offered surgical AVR because of underlying comorbidities. And after extensive discussion with the patient, it was deemed that this patient can benefit from a transcatheter aortic valve. The first TAVR was done in an antegrade fashion. By that, I mean they went through the vein, transeptal puncture, go back to the left ventricle, and then the aorta, and then deploy this aortic valve. Lo and behold, you see the moment the valve is deployed, the gradient significantly improved. And here is Dr. Previa and our patient within 15 minutes after TAVR. So excellent recovery, great hemodynamic outcomes, and the valve is considered as, can be offered in selective cases. And what are those selective cases? Because it is still investigation, we do not know how long the outcomes would last and how long is the shelf life of the valve itself. So initially the cases were primarily those who are very high risk for surgical AVR or who are not a candidate for surgical AVR. Almost 3 to 4 years of multiple cases all over the US and Europe. FDA finally approved the transcatheter aortic valve under investigational device exemption for a randomized trial. And there are two sets of randomized trial, one evaluating the balloon expandable valve and second self-expanding valve. And these series of trials evaluated the TAVR at different risk stratified patient, initially high risk, then intermediate risk, and then lower risk. And this is arguably one of the most significant sequence of clinical trial in modern cardiovascular medicine. I will talk about the partner trial, which was the first trial evaluating the role of transcatheter aortic valve in patients who are either deemed inoperable, which means STS more than 15, or higher risk, which means STS of 8 to 15. What was done, patient who was inoperable, there's no option of surgical AVR. So they underwent randomization with conventional therapy, which is usually BAV or sometimes not even BAV because that is too high risk, or a TAVR, which could be transfemoral or transaortic. The high risk group was randomized into 1-to-1 in two arms. One with the transapical, second was transfemoral, and both were compared head to head with surgical aortic valve. Interestingly, the inoperable arm was designed for superiority because there's nothing, there's no surgical arm to compare with. For the high risk group, it was designed for non-inferiority. This led to several multiple, publication, initially with 1 year outcomes, then 2 year outcomes, and now we have 5 year outcomes. So I'll focus on those 5 year long-term outcome after transcatheter aortic valve replacement in high risk and inoperable patients. The inoperable cohort was 1B, and here you can see in the blue line showing the outcomes in patients who underwent TAVR versus those who had standard of care, which is, as I said, either medical therapy, supportive care, or BAV. And this clear-cut mortality benefit with a mean survival of almost 30 months in TAVR group compared to 11 months in standard care. What about patient who underwent surgical aortic valve replacement? How TAVR does compare to SAVR? In that subgroup, there is no difference in either of the arm, and this continued almost 5 years. And what about the hemodynamics? How the valve function? Is there is a deterioration of this transcatheter valve compared to surgical valve? And answer is no. The both valve, surgical valve and the catheter-based valve did exactly same performance over next 5 years, and there's no structural valve deterioration which require reintervention after TAVR. And this was up to 5 years. This led to further evaluation of TAVR in patients who were deemed intermediate risk. And by that, I mean STS of 4 to 8, how TAVR performed in that patient population. This trial was partner 2A, and it has 2 arms. First, we assessed if patient can get transfemoral TAVR. If they have suitable anatomy, they were randomized 1-to-1 with transfemoral TAVR and surgical AVR. If the femoral access is not adequate, they were offered alternative access, which was trans-aortic or trans-apical. And then they were randomized for surgical aortic valve versus catheter-based AVR. Primary endpoint was a composite endpoint of all-cause mortality or disabling stroke at 2 years. And results were published in 2016. And here you can see on the KM curves, there is no statistically significant difference in the patient who underwent surgical AVR versus catheter-based AVR. That's so much so that the patient who underwent transfemoral TAVR, they have better outcome compared to the surgical AVR. Not so much for the alternative access. What about if we follow this patient from 5 years? Now we have data even for that. Even after 5-year follow-up, there's no statistically significant difference in terms of a death or disabling stroke in either of the arms, surgery or a TAVR. So we know that valve is durable, the clinical outcomes are durable, and patients continue to do better even after 5 years. When we take a closer look in the TAVR and the SAVR arm based on the access, you see the femoral route is performed equally as good as surgical AVR, but the alternative access after 2 years tend to do somewhat inferior compared to the surgical AVR. And this was also reported in other clinical outcomes, that TAVR is an excellent way to improve resource utilization in a hospital by decreasing procedural time, decreasing ICU stay so that ICU beds, they can be used for other patients. Usually the length of stay is 2 to 3 days. At that period of time, now it's almost 1 day. And overall, patient quality of life also improved. So now with this great result, we know that TAVR is here to stay, and more number of AVR procedure will be via transcatheter route. And this was also evident in the numbers. From 2014 to 2018, the number of TAVR across the country almost tripled from 16,000 to 58,000. And in 2018, it was significantly more than the surgical aortic valve procedures. And during all this time, the technology also grew leaps and bounds. Initially from 2007, when FDA first provided investigational device exemption for the trial, leading to 2011, when the TAVR was first commercially approved in high risk or inoperable patient, to 2016, when it was approved for intermediate risk patient. The device went 3 generations. And now we know that initially we only have 2 procedures in 2 sizes, 23 and 26. Now we have 4 sizes available, which means we can treat wider range of patient without causing significant trauma to the patient annulus and the aortic valve. And this also improved our sheath size because all these patients are they're elderly, they have various degree of peripheral artery disease. Sometimes you cannot offer them a large bore access, which was 22 to 24 French initially. Now we can perform this procedure with as small as 14 French and sometimes 16 French sheath based on what size valve we're using. So this set up the ground for next stage, which is the holy grail of aortic stenosis, low risk patient. We're talking about, inoperable, high risk, intermediate risk. They only form 20%. What about 80% patient? Are they candidate? Can they be offered this procedure, which has great outcome, has quick recovery, and almost equally efficacious in at least in high and intermediate risk patient than surgical AVR? So this was investigated in two randomized trials. One was a partner 3 trial, which studied balloon expandable aortic bioprosthesis. And second was Evolute low risk trial, which studies self-expanded aortic valve in low risk patient. In the partner 3 trial, patients who have STS score less than 4 as deemed as calculated by the heart team, which include cardiac surgeon, interventional cardiologist, and referring physician. They were randomized in 1-to-1 fashion, either for a TAVR or surgical AVR. The primary endpoint was a composite endpoint of all-cause mortality, stroke, CV rehospitalization at 1 year post-procedure. This is the baseline characteristic summarizing that the average, the mean age was 73 in both TAVR and the surgical arm, with the mean STS of less than 1.9. So they're really low risk patient, and almost other clinical characteristics were almost similar in both arms. And when we follow this patient to 12 months, there was a great statistically significant better outcomes in patients who underwent TAVR compared to surgical AVR. The primary endpoint was 8% in TAVR group to 15% in surgical AVR. And if we further hone down to the individual endpoints, the mortality was not different in either arm, but stroke and rehospitalization was significantly lower in patients who underwent TAVR. And this was also manifested in other clinical endpoints like lower rate of atrial fibrillation, shorter index hospitalization, improvement in patient symptom, improvement in the 6-minute walk distance, which means how far patient can go without being symptomatic, and heart failure score, which is KCCQ score, to evaluate their overall quality of life. And this was very well summarized by Dr. Braunwald that this is a historic movement when this was presented in ACC 2019 and covered very widely by the media because this is a historic and landmark achievement in cardiovascular medicine that patient from low risk to intermediate high risk, all of them can be offered this procedure, which has excellent outcome and even do better than surgical AVR, at least at 1 year follow-up. So what about in a big picture when we pool data from all randomized trial which evaluated patient who underwent TAVR versus surgical AVR? And if you pool all the data, there's a mortality reduction with TAVR, 17% mortality reduction with a TAVR up to 2 year follow-up. And this is primarily driven by patients who underwent transfemoral route compared to alternative access. Both balloon expandable bioprosthesis and self-expandable bioprosthesis do equally well. And patient who underwent TAVR also has lesser incidence of acute kidney injury, had 66% lesser new onset atrial fibrillation, and significantly less incidences of major bleeding requiring blood transfusion. And this was very well reflected in the 2020 AHA-ACC guidelines for management of valvular heart disease. This is a congested slide, so I'll walk you through the main bullet points here. What new guidelines recommending is if patient has high surgical risk score, that is STS of more than 8, and their life expectancy is more than 1 year, and if their anatomy is suitable for transfemoral TAVR, they should be offered one. That's class 1 recommendation. And if you see, there's no role for surgical AVR in high risk. If the mean survival is less than 12 months, then palliative care should be offered to patient. What about patients who are not high risk for surgical AVR? Then the decision is driven by the age of the patient. And the reason to do so is primarily still there's an ongoing concern about durability of TAVR valve because of lack of long-term data. And the current recommendation is if patient is more than 80 years of age, should be offered transfemoral TAVR class 1 recommendation. And if you see surgical AVR was downgraded from 1 to 2A. In patients who are younger than 65 years of age, they should be offered surgical AVR because of the concern about or lack of data for long-term durability of the TAVR valve. Patient between 65 years of age to 80 years of age should be discussed by the heart team, and based on the discussion, patient anatomy and patient preferences, we should decide about the appropriate modality, SAVR versus TAVR, both are class 1 recommendation. With that being said, the guidelines are almost crystal clear. There's a large number of patients who are still not offered AVR, either surgical or a TAVR. And the percentage of patient can be, from various studies reported 30% patients to almost 60% patient not undergoing AVR despite having severe symptomatic aortic stenosis. And if we investigate the reason why it is so, one of the most common reason is patient refusal because of lack of understanding on patient behalf about this procedure. That's a low risk procedure. The recovery is quick. This has not been educated through the healthcare system. Almost, I would say 80 to 90% of the patients in this particular studies was not even referred to a complete heart team, which can also explain the lack of AVR treatment options in patient who is severe symptomatic aortic stenosis. And often the time they were not even labeled correctly, because if you're not really parallel to that aortic velocity, aortic jet, you can underreport the aortic stenosis severity. Sometimes the symptoms are not labeled correctly. If you don't hone down the history to the patient, how you feel when you walk, sometimes they don't exert themselves to be truly symptomatic. So all that is the onus on the part of the primary care doctor and the whole healthcare team to ask and take a good history, find out the symptom, and if they are secondary to the aortic stenosis, they should be referred to the heart team or at least to a cardiologist who can further carry on the workup and the treatment plan. So with that being said, what is a look forward in the world of TAVR? First, right now we have 3 aortic bioprostheses approved by FDA. First one is the Edward Sapien balloon expandable, and the second is a self-expanding Medtronic prosthesis. Lotus is approved and then subsequently recalled because of concern about the delivery system. And recently, a few months ago, we have a third one, Portico, valve also approved by the FDA, but only in the high-risk patient, not for low-risk patient yet, because of ongoing trial for the same valve. As we move along, there are several other valves coming into picture and might be approved in near future, and that will drive down the cost of the valve and might provide the better accessibility across other patients, because right now finances is under concern because the valve itself costs $30,000. With the expanding and the more competition in the market, it might drive down to hopefully in high 15 to 25,000 is what the expected valve cost. If more clear come into picture here. With that being said, it is expected that given the great result across all patient population, the number of AVR would be predominantly by TAVR modality. Almost 3/4 of the AVR by 2025 would be TAVR because of the improved valve technology and greater safety profile with a transcatheter valve compared to surgical aortic valve. And as we move forward, there would be shift from how to treat. If you see for till now, the concern was surgical aortic valve replacement versus transcatheter. And this focus would be shift to who to treat. Because till 2022, we are focusing on symptomatic severe AS. That's what the guidelines recommend to offer TAVR or surgical AVR in most situations. But what about severe asymptomatic AS? Can those patients be benefit from TAVR procedure or not? This is actively studied in an early TAVR trial where we are randomizing patients who are truly asymptomatic as deemed by a treadmill test. They undergo a CT angiogram to see if they are suitable anatomy for transfemoral TAVR. If so, they are randomized for transfemoral TAVR versus continued clinical surveillance till they have symptoms of dyspnea, angina, or syncope. And so far, I was part of this trial in Chicago and Boston, and the results are promising, but still not published yet. So we'll see how it will be reported. And what about the patient who have moderate aortic stenosis, but also heart failure? Can we offer a transcatheter AVR in those patients? This being actively studied in a TAVR unload trial, still recruiting patients, so we do not know the definitive answer, but that would be interesting to see that if you decrease the afterload in a patient with a compromised alveolar systolic function, how they will do. Other studies at this time are also addressing the durability of the TAVR valve, because now we are putting these valves in somewhat younger patient population. So how these valves will do 10 years down the lane, we do not know yet, but it will be important to make sure that these valves are durable enough. If you're moving your patient population from 80-year-old to almost 65-year-old. And what about the antiplatelet or anticoagulation regimen? Because right now there's the current guidelines support antiplatelet therapy. Galileo trial studied the role of anticoagulation, but end up prematurely stopped because of concern for more harm in patient because of bleeding. The ongoing Foldex tri-valve technology, which use polymer, not the animal tissue, to make the valve, might eliminate the concern about the anticoagulation or antiplatelet, or even the durability, because in the animal model and in the investigational data show it's way more superior than the animal tissue in terms of durability, but still not approved yet, still investigational. What about patients who have aortic regurgitation? If you remember, I started the first transcatheter valves were primarily used in patients with aortic regurgitation. Right now, this is off-label use. We can implant a transcatheter valve in patient with aortic regurgitation, but patient need to have some severity or some degree of aortic stenosis, because all these transcatheter valve rely or based on that annulus to provide the support so that they don't embolize. What about patients who have no calcification? Can we implant a transcatheter valve in those situations? Not the current generation valve, but the new investigation valve, which might provide support by hinging the native aortic leaflet. This is investigation and undergoing the studies, not FDA approved yet, but can be used in selective patient population based on the patient anatomy. That being said, I'll end here by a quick question. And the question here is, what do Henry Kissinger and Mike Jagger have in common? And this is open to all. If anybody can raise their hand and answer this question.
TAVR.
That's right. Absolutely. They both are proud TAVR patients, and they're doing great. So here you go. You have, even from a common man to a rock star. All of them have been offered this treatment and doing very well. And we're planning to have this therapy available, hopefully, in our patient also, based on how our discussion with the leadership go. I'll stop here and take any question if we have any.
Thank you, Dr. Sharma, for this really great overview on what you really had described at the outset of revolutionary technology and a really revolutionary advance in cardiovascular medicine to be able to implant these aortic valves. Let me just pick up on your last point. You want to talk a little bit about what the plans are here for the structural heart program under your leadership?
Thank you, Dr. Clapples. Yeah, so before joining Rutgers, I was running a structural heart program up at Wisconsin, and we did more than 250 TAVRs. And the whole arena of structural heart is not limited to TAVR alone. There's a wide varieties of procedure which we can offer our patient, including transcatheter S2S mitral valve repair, known as mitral clip in more common language. Also, balloon mitral valvuloplasty, balloon aortic valvuloplasty in select patient. And we are planning to have that full-fledged structural program here at Rutgers University Hospital. And I'm happy to share with the group that so far discussion with the senior leadership is very supportive, and we are looking to start our TAVR program hopefully very soon. I would not put a time limit to this because it's still evolving discussion, but I'm very optimistic that in a spring might be a reasonable time frame. Dr. Clapples, do you think that's fair to say?
Yeah, I think it's very fair to say, and it's absolutely what we've been striving to do. And under your leadership, I think we'll get that going hopefully within the next month or so. I mean, I think we're really pretty close, as you know, and been doing a lot of work in that arena. And also, as you indicated, we'll have to have you back for a second talk about treatment for mitral valve disease as well. So that's going to be, I think, very exciting.
Absolutely, because as most of us, might have already encountered that in our unique patient population, mitral regurgitation is very prevalent, way more than the national. The varieties of reason because of non-ischemic cardiomyopathy, hypertension, and things like that. But I think the mitral clip program would be a very robust program in this area, given our patient population. So I'm looking forward to that. Yeah.
Thanks. I want to encourage people to either raise their hand or put something in the chat. If you have any questions, we'll be glad to go around the room. So please go ahead and do that. While we're waiting on that, let me just ask, you made a really, I think, you made some great points. One of them, I think, that's really super important, especially in our patient population, is often the presence of mixed disease. You have cardiomyopathic disease, and then you have valve disease. You mentioned this TAVR Unload trial, which is looking at moderate aortic stenosis in patients perhaps with underlying cardiomyopathy, and whether just by doing something for the aortic valve, you may help improve the overall outcome related to the cardiomyopathy. Very, very, very interesting. In general, we know the aortic valve, normal valve area is about 2.25, 2.5 centimeters square. And what valve area, and especially we have such a large primary care group of physicians and patient population, what valve area would you recommend referring a patient to the heart valve team?
Yeah, I think that's a great question, and I would say, given an audiences, we have primary care doctors, family medicine doctor. So if they encounter a patient where the valve area reported on the transthoracic echocardiogram is less than 1.7, please send it to us, and I'll share my number. If you have directly send them to valve clinic, we'll take it from there if they need to further evaluate it, because not all moderate AS, quote unquote, is a moderate AS. We need to, sometimes we underreport the aortic stenosis because of the nuances in the transthoracic echocardiogram, how it was measured. So it might fall in the realm of more expertise and to non-invasive cardiologists or a structural heart disease specialist. And I would strongly encourage our colleagues here to, if they encounter anybody in their practice with a reported area of, less than 1.7 to 1.5, or even if they have any doubts, let's say they're not sure about it, send it to the valve clinic. We'll evaluate. We're happy to provide the further care to the patient, and if they're candidate for AVR, we'll provide them that therapy too. Yeah. So anybody
Thank
with
you.
yeah, go ahead.
Yeah, from Dr. Bleich, from endocrine, the question about a high rate of aortic stenosis in the diabetic population, and have TAVR studies looked at this population specifically?
Yeah, so I think that's a great question, and that's why there's no trial per se studying diabetic patient, but if you kind of dissect the data from multiple randomized trial, now we have more than 8, with the balloon expandable valve or self-expandable TAVR prosthesis, patients who are diabetic or non-diabetic, they do way better, and their outcomes are similar if you offer them TAVR versus SAVR. The recovery time is way faster because of the diabetic patient tend to heal later after surgical AVR. So I would say that is a patient population which can be, we have added advantage of quick recovery compared to the surgical, depending upon how bad is their diabetes is, which can impair the wound healing after surgical AVR. That being said, the current labeling by FDA in 2019 is low risk patient, irrespective of their diabetes status, irrespective of their anatomy. It could be bicuspid aortic stenosis, it could be a trileaflet aortic stenosis. So any patient, irrespective of the comorbidities, can be offered TAVR if the anatomy allow, and that is determined by the heart team based on the CAT scan, based on the other investigation studies.
Thank you. Again, I'll encourage people to put the question in the chat or raise your hand or speak up. That'd be great. Let me just also, while we're waiting, let me just expand on this area that you also mentioned. We know, classically and historically, aortic stenosis is a very insidious disease, slow in onset, progresses over sometimes decades of time. And as you have noted, this patient population is often present in the elderly, who then show up with functional impairment that's often attributed to age, as opposed to really being related to the fact they have markedly reduced cardiac output from their fixed aortic stenosis. Where are we? You've alluded to this. Where are we in exploring really this optimal point in time of when we should be really replacing these aortic valves? And you alluded to some of this moderate AS, but even in the absence of underlying cardiomyopathy, what do you think about this issue? It's always been a problem. People show up, they're already functionally impaired, they're already elderly, they're already more frail, that already impacts their outcomes. And how do we know when we're kind of missing the boat in time?
Yeah, I think that's a great question, and this is a big clinical dilemma for all of us. And I want to go back to my slide, which is really the first time when it was reported about the symptoms and the prognosis, so to say. And the conventional thinking is that you wait for a symptom to really you have to have symptom before you even started the investigation further or offer the workup or start the workup for a AVR, catheter based or surgical. But that's not really true. That's not really true, because as you alluded to, that with that degree of stenosis, your left ventricle sometimes compromised, which might not be clinically manifesting in terms of symptoms. So do we really need to wait that long so to have the patient start being symptomatic, or we should intervene earlier? And this question is studied in early TAVR trial, as I mentioned before, where there's a lack of symptom, and lack of symptom is truly lack of symptom, because as you mentioned, sometimes patients are having limitation because they are having musculoskeletal issues. They have other they have anemia, which they think they cannot exert themselves, or their symptoms were kind of mislabeled. But if you tone down and if you just really take a good history, say there is a no symptom, you prove that to me by putting patient on treadmill test, and they are still asymptomatic. Even in that population who are truly asymptomatic but have severe AS, they can be offered AVR as a part of the ongoing trial, not recommended yet. What about the moderate AS? Moderate AS in setting of compromise LV might be an indication for AVR in near future, not now, but still part of investigation. And the underlying reasoning to all this is that if you have narrowing of the aortic valve, it increases the afterload and it actually burn down your left ventricle. So how soon you should intervene is still kind of a moving target, but the needle in this gauge is in this scale is moving to the left, which means sooner intervention might be better. At what exactly cutoff, what is the exact cutoff is still not decided, but my impression is definitely severe aortic stenosis, even if it's asymptomatic, would be listed as an indication. For moderate AS in setting of compromise LV, yes. In setting of preserve LV, maybe not.
Thanks very much for that, and we'll be looking forward to, of course, these developments as time goes on. Question, I think one of our residents, our particular preferred antiplatelet agents, which you've mentioned a little bit about, are antihypertensives post-TAVR.
So that's great, and I would say when I was talking about drug therapies, and this is about in patient who did not prevent AVR, surgical or catheter-based. In that condition, there is no role of medical management. But post AVR, especially in the TAVR population, there is an increasing amount of data supporting role of ACE inhibitor or ARB. And the reason for that is LV remodeling, which secondary to ACE inhibitor or ARB. So yeah, that can be that should be considered. If patient is hypertension and there's no contraindication for ACE or ARB, that should be considered as a therapy for their hypertension per se, because of remodeling effect from ACE and ARB.
Thank you. I do see we have one of our cardiothoracic surgical colleagues on, and if he would like to comment, clearly this is, and I think that you have mentioned this, clearly this is a partnership with our cardiothoracic surgical colleagues in the assessment of patients and ensuring that the appropriate access is undertaken. And there are some instances where direct access does require surgical intervention.
Yeah, thank you, Dr. Klappholz. This was a great talk, Dr. Sharma. I'm thoroughly excited and eager to embark on this program with you and Dr. Klappholz. This is an exciting time for University Hospital, and I have full faith in our leadership that we can move forward with this. We have a unique population, and yes, I agree that our structural capabilities will enhance our capabilities to take care of this important population. And yes, the heart team approach before and after surgery, for a procedure like this is incredibly important. And one of the things that we see a lot here is endocarditis. It's important to note that TAVR is probably not an indication for that specific subset because of the underlying infection. But there are plenty of patients here that would benefit from this technology, and this will expand our capability, and specifically Dr. Sharma and Dr. Klappholz's ability to offer the MitraClip moving forward. And cardiac surgery, we're here to operate on those cases that are not candidates for these procedures, but also to provide that guidance for the right candidate.
Thank you, Dr. Shakir. I would say, the TAVR is a great testament to the heart team model, and how much we can achieve by interdisciplinary approach, where all the experts from relevant field come and contribute for a better patient care. And the great outcomes we have from the TAVR experience has also been implemented now in other other procedure or subspecialty like brain team model, where a collaboration between a neurologist and a cardiologist in patient with a stroke care is still we are still exploring that approach. But definitely for the TAVR and for CLIP and other structural heart disease procedures, heart team is a way to go. It's recommended as class one, by both ACC and HA. And I think that's the right thing to do. Both surgeons and interventional cardiologists need to work together to provide the best outcome and the best access to the patient. Absolutely, yes.
I'd like to specifically thank Dr. Shakir, who has been a great partner with us in cardiology, not only in this program, but on other things. We're doing the AngioVac program, which has really helped the treatment of infective endocarditis on the right side of the heart, and has been a partner every step of the way here. And we really do greatly appreciate that. And as Dr. Sharma just said, it's not something you do without partnering together equally with cardiac surgery to ensure that we make the best decision for every single patient. So I want to thank Dr. Shakir, who's really been absolutely just a terrific and great partner on all of this, on all of the work that we're doing in cardiovascular disease. So thank you. Just alluding actually to, there's a question from Dr. Sutherland about endocarditis, and you want to expand on what Dr. Shakir just was saying about its role or lack of role in infective endocarditis?
Yeah, so no, thank you, Dr. Sutherland. So I would say this, as Dr. Shakir mentioned correctly, that if patient has active infective endocarditis, the concern to implant a prosthetic valve is it can be nidus for further infection, and it's not a good idea. It's not supported. You really have to clear that infection. And let's say patient is clear of the bacteremia, clinically improving, but still have stenosis or regurgitant lesions. Can we offer TAVR in that patient population who have a healed infective endocarditis? Not by the current guidelines, but off-label use can be. I have personally performed the cases where there's a healed vegetation and there's a regurgitation, severe aortic regurgitation with some stenosis, but infection has been cleared. In that situation, I think it's reasonable to have a heart team meeting and discussion and explore the options which is the most helpful for the patient, but not in setting of active infection.
Thank you.
Sorry,
another question? Yes.
Yeah, Dr. Klappholz. Yeah. So a wonderful talk, Dr. Sharma. One other area in terms of the collaboration that you alluded to, and I think would be a source of additional patients who deserve this procedure, is the echo lab. I mean, those of us who read the echoes see, peak velocities greater than 4, aortic valve areas less than certainly 1.7, but even less than 1.2. And we don't see that they've been, intervened on. And I think with the presence of this procedure, even looking through our echo records, will provide another source for patients.
Thank you, Dr. Carter. Thank you so much for this comment. And absolutely, I 100% agree. And I'm glad to share with the group. Dr. Waller and I are working on this, and we are looking for the patient who have the number that you mentioned for which qualify them for aortic severe aortic stenosis, and then further investigate if they are candidate for a transcatheter AVR or even surgical AVR.
Yes, and just one other question: are there any data yet on TAVR in TAVR or TAVR in SAVR valve replacements, and do you think that will be another source that we can help patients with the TAVR procedure?
Yeah, absolutely. There is a plenty data available. There's a lot of if we look into the national NCDR TVT registry, which reported 82,000 of TAVR procedure, and several of them with valve in valve, either inside the old TAVR valve or surgical bioprosthesis. And these cases are somewhat more challenging than your native aortic valve, but still provide great outcomes. there's a different technical nuances how we can optimize the hemodynamics and which valve we should use, intra-annular valve versus supraannular valve. But absolutely, yes, patients who have severe degenerative stenosis of the prior bioprosthesis, could be surgical bioprosthesis, could be catheter-based, they can be offered valve-in-valve TAVR. Even third procedure, valve-in-valve inside of the valve, has also been done.
Wow.
Okay.
Thank you.
All right, well, I want to, our time is up. I want to thank you, Dr. Sharma, again, for a great presentation and discussion on this really exciting technology and medical therapy. And we certainly are looking forward to it here at University Hospital. I want to thank everybody for joining this morning, and I hope that you enjoyed this terrific presentation, and wish you all a great rest of the day. Thanks so much.
Thank you, guys. Thank you.